And good morning, I'm Dr. Deuk, and we're broadcasting live from Surgery Center Viera and Deuk Spine Institute. Live spine surgery, Tuesday, June 18, 2024. Our first patient is from Miami. She has multiple disc herniations in her neck. We're going to be fixing two of them, the two worst ones, number 3, 4, and 4, 5. Did you verify?
3, 4, 4, 5.
Our patient is asleep. She has a tube. She's on a ventilator. Our anesthesiologist is monitoring her. Anesthesia cases are done outpatient. This is an outpatient surgery. We are not at the hospital. We don't want to be at the hospital. Hospital is where people go when they're very sick. The first step is going to be accessing the spine. And specifically, we want to access 3, 4, and 4, 5. Shot? So the needle is a little bit low, 2, 3, 4, 5. I need to be a little bit higher in the neck. So I'm going to move up a smidgen. Shot? That's much better. So we'll start at 4, 5. Let's get an AP view. My fingers are displacing the soft tissues to feel the spine. When the patient is asleep, good, lateral. You can actually palpate the spine with your fingertips as long as they're asleep and relaxed, and she is. All right, so I'm going to go in, shot. All right, so I feel like I'm off to the side. Give me an AP. So I'm not going to go any further until I get a front back view. 2, 3, 4, 5. I'm off to the side. So we need to come back towards me. And shot. That's better, but still a little bit too far to the side. And shot. Let's see. All right, lateral. So the first step is getting into the spine, and her neck is very supple, very, very nice. There's a little bone spur there, shot. Now let's see where that is. That should be in the middle. Quick AP. Shot. All right, that looks better. We're still off on rotation. Derotate it, please. All right. All right. That looks good. Give me a lateral, please. AP and lateral are two different x-ray views, one from the side, one from the front. I'm going to enter the disc, and let's just see where we are. Give me a Coker, AP. Derotate the neck, please, anesthesia. Give me a true AP. All right, let's see, make sure we're in the middle. 2, 3, 4, 5. That's perfect. All right, we're in the middle. Let's go back to a lateral view. Now, what kind of treatment could she have with her herniated disc? She could have an ACDF, which is an anterior cervical discectomy and fusion. People don't want fusion. I don't blame them. It's highly invasive. Shot. They could have artificial disc put in. But then again, you're putting a piece of metal in your neck. You could have a laminectomy infusion or just a laminectomy. The problem with laminectomy, highly invasive, painful, scar tissue, bleeding, and deformity afterwards. Shot. I'm injecting some dye. You can see the tear in the back of the disc. That's what we're here to fix. She's got a combination of herniation and bone spur. We're going to try to get out as much as we can endoscopically. Injection. If you have questions, feel free to ask them, type them up, and we'll do our best to answer them. Henry is at the helm. He will be relaying your questions to me. In the meantime, we're going to make a 4mm incision. Henry, show the audience how is it that a disc injury can be so painful for patients? What's the mechanism? Welcome back. We have you watching our classic oldie but goodie video showing how a annular tear then becomes a herniation, which then causes inflammation and pain. And that's how people get neck pain, folks. 90% of neck pain comes from disc injuries, just like the one you saw in the video, where there's inflammation happening. And Deuk Spine is the first in the world to discover that. We're the first to identify the source of pain and the first to fix it. Specifically targeting that area. All right, we're advancing our our tube over the dilator. I'm going to pull the dilator back just a little bit. Shot. And then I can advance the dilator again near the end if I need to. But the entire surgery is done through a metal tube. That tube is sliding right over the dilator now. I have my anesthesiologist giving me some inline traction, and we're just moving nice and slow right through the disc. Now some people, they think it looks like the whole disc is gone, but it's not. Actually, we're just moving through the disc. And if you look at the AP view, you realize how little we actually, of the disc we're actually occupying. It just looks like a lot on the side view. Almost there, guys, a little traction. I'm gonna bring the dilator in a smidgen. Shot. Yeah, shot. And then I'm gonna take the tube right over it. Shot. All right, let's see if we can bring our tube just a millimeter more. A millimeter is actually a lot in spine surgery and brain surgery. It doesn't seem like much in most of our lives, but a millimeter can make all the difference in the world between a successful procedure and an unsuccessful procedure. Or symptoms, or no symptoms. Any questions?
At this moment, no current questions.
Let's show our audience how the Deuk laser disc repair works in the neck to clean up the tear, remove the herniation as much as possible, all without putting metal, all without hospitalization, all without an major open surgery. All done minimally invasive. I got it.
Copy that.
Welcome back.
The top.
You can see from our video that the laser is being used to basically clean. There's a piece of herniation right there. You guys see it, the blue?
Yes,
Here
we
it
do.
comes. Now, this herniation is a good size, probably about 3 or 4 millimeters long. I'm gonna try to grab it out with the grabber. We're taking the laser out. We're gonna bring in the pituitary rongeur. I don't know if I'll get it or not. Looks like we got it. So take a look at this. White. Can you guys see this here, Henry? Bring me the measuring stick.
Yes, we can.
So it's not really that big, but if you add up all the pieces, okay, that's a good, 3-4 centimeters long and 3 centimeters wide. Millimeters long and 3 millimeters wide. So that's just one of many herniations. We've already taken out 3 of them. That's the third one. And this is the number 4-5 disc. Here's some bone spur here. And that's the foramen over there that we're working on. That's the left foramen. There's a little bit of herniation here. But the surgery is very specific. We're literally targeting, that's bone spur, we're targeting a very small area in the back of the disc, okay? And when people ask me, why don't you get an MRI afterwards? And the answer is because you're not going to see much difference. We're not trying to make big changes. We're trying to make small changes. That's what minimally invasive surgery is about. But these small changes have the ability to have a big effect. Small, big effect. Structurally small, but physiologically a huge effect. All right, any questions?
Yes, we have a question coming from Lanu on YouTube
Hello, Lanu.
asking, sometimes I see people bound in wheelchair with severe spinal injury. Do they also have herniated disc?
Great question, Lanu. If they're in a wheelchair from a spinal cord injury, then they're probably traumatic injuries from car accidents or falls, and typically those are not herniated disc issues. Those are what are called fracture dislocations. And we don't treat fracture dislocations at Deuk Spine. Those are not what we treat. Those are treated in the hospital with emergency surgery usually, okay? So I would say no, that's not the same problem we're treating. Now, I used to treat those all the time when I worked at a trauma center, and those are, to me, very unfortunate cases because there's not much you can do. But generally, issues with the spine can be resolved with proper surgery. Issues with the spinal cord, which is the very delicate nerves found inside the spine, when those are damaged, they never heal. They never repair themselves. So unfortunately, those patients carry a lifelong deficit that is not fixable with modern surgery or any treatment. Now, they're developing robotic interfaces, computer brain interfaces that will eventually allow those people with spinal cord injuries to walk again and function. But we are still 30, 40 years away from fully integrated adaptive technology that can overcome motor, sensory, and bowel and bladder dysfunction that occurs with spinal cord injury. So I think it's on the horizon. As a matter of fact, I've talked about it before. It was my idea to interface the muscles with the brain to bypass the injury in the spinal cord as a neurosurgery resident back in the 90s. And I had done research on, rabbit brains, Alzheimer's disease. I was familiar with the cerebral cortex and microelectrode arrays recording from my research at UC San Diego with Dr. Lou Cornacchia. And what happened was I started to think about how we could bypass the spinal cord that's injured using basically computer chips and circuits to go directly to muscles, to allow muscles to be controlled through the brain, through alternative pathways. May need a new cervical scope, unless that's water. Well, could be water. but I think it's the glue. Yeah. I have a bad feeling it's the glue between the fibers because I was really pushing on the scope. So let's see if we can correct this. All right, any questions?
Yes, we have a couple more questions. This next one coming from Renz on Facebook.
Renz?
Renz, R-E-N-Z, Renz.
All right, Renz. Oh, we're okay here. Do not open it yet. It just shifted the focus. Yes, Renz.
Saying, hi, Doc, is there any difference on MRI plain versus MRI with contrast? Is contrast more accurate to check the nerves and the discs? Thank you.
Yeah. Do not get a contrasted MRI. It's completely unnecessary for degenerative conditions like these, like discs. Never, never, never get a contrasted MRI. Now, MRI contrast is called gadolinium. It's pretty benign stuff, but it's not necessary and it doesn't help with any diagnosis at all. The only time you need contrast dye is if the patient is suspected for an infection or a tumor. Infection or tumor, that's when you get dye in your MRI. But other than that, you do not ever get dye. It's completely unnecessary. It doesn't help at all. Now, some doctors, old school, will get dye for looking at scar tissue. I was trained to do the same thing. However, it's totally useless, unnecessary, and it can harm the patient. So you always have to weigh the risk and the benefit. There's a herniation. Look at that thing. That thing is too big to come out, so I'm going to chop it. We call it bivalve. Bivalving. If you all know what a mollusk is, it's a bivalve. There are bivalve mollusks like clams and oysters. So that's where the terminology comes from, but essentially you're making it smaller so it'll come out easier. That's really what we're doing. There's a good herniation there. Almost done with this disc. So do not get an MRI with contrast. Some doctors will order it because you get paid more to do an MRI with contrast than without. And some doctors, unfortunately, they do things for the wrong reasons. Anyway, we are literally in the foramen. That's a half a millimeter fiber, by the way. I'm going to check the other direction and we'll be done with this disc. I think there's still a piece of herniation over here. Yeah.
We have another question
I'll take it.
coming from Charlie on YouTube,
Yes, Charlie. Happy to take your question. Welcome to our live stream.
asking why did and or do you choose to utilize a laser rather than other types of tools that work with the endoscopic method of decompression?
Charlie, other tools do not work with the endoscopic method of decompression. I'm not sure where you get your information. But the laser fiber here is half a millimeter or 0.5 millimeter. There is no other tool that works as well as the laser or even takes the place of a laser. The other surgeries that use non-laser technology are inferior. The results are not as good. Get as good a result. Our surgery that you're watching, the Deuk laser disc repair, has the best outcomes of any surgery in the world for a cervical disc. Any surgery. Best outcomes means relief of pain in the neck, relief of headaches, relief of arm symptoms, and complication rate, recovery rate, use of post-operative analgesics. This surgery is better than any other surgery on all counts. Getting back to work, getting back to normal activities. We don't put any metal. Other surgeries, endoscopic surgeries, are far more invasive and damaging to the body. So, not sure what you're referring to, Charlie, but actually your statement is completely false. All right, almost done. We ran into a big piece of herniation. We're breaking it up into little pieces with the laser, not possible with any other tool. And just about done here. Again, this is 4-5. We got to do 3-4 next. This is all scarred, calcified herniation. And you can see the posterior ligament, fibers there, bone spurs. We're taking them all down with the laser. Any other questions?
No current questions, but we do have a comment from Jonathan on YouTube who said that you did answer his question with the answer was 0.5 millimeter fiber.
0.5 millimeter. Yeah, the glass fiber is 0.5 millimeter. There's nothing in medicine that's that fine that can be put down an endoscope. This is the finest, smallest, most accurate tool. And by the way, the accuracy in my hands with this fiber and endoscope is 0.5. 0.05 millimeters. That's, take a millimeter, divide it into 20 parts. That's how accurate I am with the fiber laser. There is no surgical tool that comes close. If you have a normal surgical tool that other surgeons use, they can get down to about a millimeter of accuracy. We're 20 times more accurate. And that would be endoscopic, by the way. Without endoscope, their accuracy would be 5 millimeters. So we're 100 times more accurate than a non-endoscopic spine surgeon, which is 98% of spine surgeons worldwide don't use an endoscope. And we are 100 times more accurate with this laser and endoscope than they are. So who do you want? You want a surgeon that has 100 times more accuracy, or one that's just kind of scraping around, muddling around back there without being able to see what they're doing? You see, these herniations can be, 1 millimeter or less. So if you can only see 5 millimeters and you've got sub-millimeter herniations, that's why so many people do bad with spine surgery, because the surgeons aren't doing a very good job. No, I don't think we do. The neck is pretty thin. Shot? All right, we are done with one, getting ready to do the second disc. I just need the head and shot. Can you please take some of the front away there, Jordan? I shouldn't have to tell you that. All right, 2, 3, 4 is next. Everyone agree? Let's rock and roll. Here we go. I'm coming out. We're going to do the Deuk slide, the Deuk spine slide, which I developed here for doing multiple disc herniations in the neck. At the time I was trained to do this surgery, there are only 2 places in the world you can get anterior cervical endoscopic surgery. Germany with Sebastian Reuten, and South Korea with Dr. Sang-Ho Lee and Dr. Gun Choi. Nobody else was doing it because the Koreans were the first and they taught Reuten. Anyway, I learned from them and became probably the 3rd or 4th or 5th anterior cervical endoscopic surgeon. And at the time, everyone was doing, Sang-Ho Lee and Korea and Germany were only doing 1 disc at a time. All right? They wouldn't do 2 discs. Shot? Because they didn't know how to do the second disc. Shot? That was a problem everybody had. All right, I'm going to be having a hammer on this, so I need you to hold it still. Shot? Go ahead and type up your questions. I'll answer them for you. A little bit off to her left. I'm going to bring it back to the center shot. That's perfect. Now lateral. So I'm happy with the AP view. Let's see what the lateral view looks like. And then we're going to advance the dilator into the disc. All right, I'm happy with that view. Shot. Shot. Let's just get another AP to verify. Coker. I always check, double check, triple check everything because you don't want to be off of where you're supposed to be. There's a very narrow window to work in. And it's perfect. And if you get off to the side, I won't even talk about it, but it would be a very bad outcome. Let's just say that. So over the years, I've learned to double check, triple check, quadruple. I mean, I'm checking constantly. Where is my instrument? Is it in the right place? Shot. Shot. There's no room for error or carelessness in this type of surgery. All right, discogram, shot. Perfect. See the tear back there? Show us the tear, Jordan. That's the tear we're going to go fix right there. Yep. And we use a laser to do that. There is no tool in the world that works better than the laser. Not even close. By the way, for those of you who have never seen it, the entire surgery is done through this tiny little tube. Here's your metrics. It's 4 millimeters. Not even a half a centimeter. 4 millimeters wide, external diameter 2. And this is from Germany, Richard Wolf. They don't make it anymore. They want you to buy bigger ones. But the way I figure it, I've been doing all my surgeries with the smaller tubes. They're less invasive, and I've had better results than any other surgeon in the world doing cervical spine surgery. So why would I change what works? In America, we have a silly old saying, if it ain't broke, don't fix it. Right? All right, we're there. Perfect. So we're at the back of the disc. Jordan, show us on the x-ray where the tip of the tube is, sitting right in the tear and herniation. Any questions?
Yes, we have a lot of questions.
Do we have the 30 causes of neck pain video yet?
Not the 30 causes of neck pain, no. But we do have the 30 causes of back pain in general.
All right. So Tambine hasn't finished it?
No, not yet.
All right. We got to get on him.
Copy that.
Will you send him an email, ask him when he's ready?
Yes. I'll do that right after
Take a look at. We got a DLDR, cervical, and we got a 30 causes of neck pain. Or sorry, 25 causes of neck pain.
Not a problem. I'll let him know.
We'll start taking some questions.
This next question coming from Jonathan, once more on YouTube, asking age of PT presented symptoms. I don't know if they're asking for this patient in specific or for themselves.
Yeah, I think they're asking for this patient.
Copy that.
The age of the patient, I can't give you their exact age, but Berndes, close. 60? So they're close to 60. Presenting symptoms was neck pain, arm radicular symptoms, right? 7 years. Also, I think they're getting headaches from their herniation. Look at the herniation right there. See that? Just pop. It's all scarred up, just popping out of where the spinal cord is. There it comes. Come on. It's amazing, huh? These little things in the back of the disc, that's all you got to fix. And every cervical spine surgery, whether it's ACDF, artificial disc, the whole purpose of the surgeon is to get here, right where we are. But to do that, they have to take the whole disc out. So when they take your disc out, well, they're stuck. They have to put something back in there. Otherwise, you'll just have bone on bone, or you'll have the bones rubbing around, wobbling around, okay? And that's going to create problems for the patient. So that's why the Koreans discovered this technique. They said, you know, why don't we just leave that disc in the front alone, and let's get to the back where the herniation is, where the problem is, and let's just fix that. So that's what they did. Let's take questions. We are at the back of that disc, 3-4.
Next question coming from Lanu once more on YouTube. Asking a non-disc question, many terminal cancer patients died despite of chemotherapy treatment. What is your view about chemotherapy?
Yeah, great question, Anu. I am not qualified to give a view on chemotherapy. That's outside my expertise. I would not be the right person. I'm sorry. I refrain from giving opinions on things I'm not familiar with enough to give a good opinion. But thanks for asking. Next question.
This next one is a comment and or seeking for advice from Charlie once more on YouTube. Saying, in my research, I've seen endoscopic decompression done at Jefferson in Pennsylvania and talks about it from Dr. Siva. I do believe that their tube and sleeve are larger to accept the tools. I've been researching because I'm very concerned about having a fusion. I was told I need a 4-level ACDF.
Yep. So Charlie, there is no universal definition of endoscopic. And a lot of doctors say they do endoscopic when they don't. Okay? You can drive a dump truck through an endoscope and call it endoscopic, but that doesn't mean it's really endoscopic. They're just lying to you, okay? That's like me catching a fish that's 12 inches long and saying I caught a big fish. And then somebody else catches a fish that's, 70 inches long, and they say, no, that's a big fish. Go watch the old Crocodile Dundee, right? When the guy pulls out a knife in New York City and he says, give me your money. And Dundee says, what is that? And he says, it's a knife. He said, that's not a knife, this is a knife. And he pulls out a knife, right? So the point is, anybody can say they're doing endoscopic surgery, but most of the endoscopic surgery that's being said they're doing out there is not real endoscopic surgery. It's fake endoscopic surgery. It's just to draw people like you in onto their social media platform. So then you go, oh, look, Jefferson does endoscopic surgery, I'll go there. They're not doing real endoscopic surgery. Unfortunately, there's no standard criteria accepted for endoscopic surgery. But you need to use an endoscope. I am. You need to use a small tube. How small? There's no definition. Our tube is 4 millimeters. At Jefferson, they don't use a 4 millimeter tube. I guarantee you that. They're using a much bigger tube. Bigger the tube, the more damage they're doing to your body. Think about that. Would you rather have a needle stuck in you or a lead pipe? Okay, a lead pipe is a lot bigger. It's going to do more damage. A needle doesn't do much damage. So they're using big tubes and they're calling it endoscopic. It's nonsense. I know everything these doctors do. I've been trained to do it. I've seen it. It's garbage. We don't do garbage surgery at Duke Spine. We do the most advanced surgeries in the world. We don't do, scamming, bullshit, fakey crap like you find elsewhere. You want the best, you come to Duke Spine. Good luck with your procedure. Hopefully it goes well for you. Thanks for participating. I'm glad you asked. It's a good question, and people need to know the truth. All right.
Teresa on Facebook
All right.
saying, hi, Dr. Duke.
Hi.
Can whiplash cause bone spurs in the cervical spine?
So Teresa, whiplash causes injury to your disc and your facet. That injury over time, over years, will cause bone spurs to form. So the answer to your question is yes, whiplash can definitely cause it, but it's not something you're going to find acutely right away. So this piece of herniation here in the foramen sitting on the nerve root, this is too big to come out, so I have to chop it with the laser. There we go. Part of it's coming out now. And by the way, when you see me come out like that, I'm floating the herniation out, literally using hydrostatic pressure of the irrigation to float it out. Next question.
Next question coming from
5
Jonathan
minutes.
once more on YouTube.
From who?
Jonathan once more on
Hi,
YouTube.
Jonathan, welcome.
Saying the white material that you're ablating is the scar tissue. Are
This-
you removing disc material? Pardon my ignorance.
Jonathan, this right here is a piece of herniated disc, but it's scarred. It's not just herniation anymore. Because over time, inflammation has scarred it. Your body has attacked this herniation, and the attack of it, it no longer looks like a piece of disc material. It's actually filled with scar tissue from the attack. Okay? So what you're seeing is disc herniation combined with scar tissue combined with calcification. Because over time, your inflammatory system attacks and your body then calcifies the damaged tissues. It adds calcium to it, so it makes it very dense. Very hard for it to come out, actually. All right. Almost done. Just need a little more work over here in the foramen. Any other questions, Henry?
This next question comes from Renz once more on Facebook.
Yes.
Asking, hi doc, what is your comments about unilateral biportal endoscopic spine surgery? What are the pros and cons?
Well, the UBE technique was developed for surgeons that can't do what we're doing here. That's really what it comes down to. And, you know, a lot of surgeons like the idea, spine surgeons like the idea of endoscopic spine surgery, but they can't do what we do because they don't have the skill set. They don't have the confidence. They don't have the understanding of the body, the anatomy, and they don't know how to use these equipment we're using. Okay, they don't have, or maybe they don't have access to it. So a company then said, okay, what if we train you on a simpler technique? Maybe it's not as good as what Dr. Deuk Majan's doing, but we'll also provide you with all the stuff you need, and the hospital will buy it from us as a package deal. That way the hospital doesn't have to buy all this equipment. And so that's where the UBE technique came about. A company that wants to make money and wants surgeons using their product developed the UBE technique and is training surgeons to do it, okay? So is it better than a microdiscectomy? Yes, in my opinion it is. Is it as good as what we do, the Deuk laser disc repair? Not even close. But it's still better than a microdiscectomy and a laminectomy, which would be the alternative surgery, okay? So I think there's advantages to it in that it's less invasive and better for the patient than, you know, highly invasive, dangerous surgery like microdiscectomy, laminectomy, but it's still way too invasive for us at Deuk Spine. We don't do it because it's an inferior procedure. It's kind of like if you want steak, we offer the best steak available. They offer, you know, hamburger meat. And you can convince yourself that hamburger meat is still steak, you know, if you've had a lot to drink. But everyone knows hamburger meat and steak are not the same. They both come from a cow, but that's where the similarities end. The UBE technique is more invasive, more bleeding, more scar tissue, more damage, less effective, longer recovery. It involves removing bone and ligament from the spine, normal bone and normal ligament that we shouldn't be taking out. We don't do that at Deuk Spine. We leave all your normal bone and ligament there. We don't need to take it out to do our surgery. All right. Next question.
Next question coming from Charlie, once more on YouTube, asking, do you often find that patients who were told they need many levels end up needing less when you see them?
I don't know, Charlie, to be honest. Good question. I just make up my own mind, but I do a lot of telemeds, and there are, I think, both ways. I see patients who are told they need one level when they actually needed 2 or 3. And I see a lot of patients who are told they need more levels when they only needed 2 or 3. But the average number of bad discs, oh, look at that. The average number of discs that we treat in a patient that's symptomatic is 2.4. So what that means is the average patient needs 2.5 discs fixed. That's just an easier way to think about it. I've seen up to 4 discs needing to be fixed, and I've seen as few as 1. But I would say the 90% of patients need more than 1 disc fixed. Let's see if I can grab that out because it's just sitting there at the bottom. Nope. No. No luck grabbing it out. Great questions from our audience today. Shout out to 2 friends, Ashley and Mark, who are watching the surgery for a family member. All right, you see that piece of herniation right there? I've been working on it with the laser. Now the gold color is calcium, and that's what happens after years of the body attacking the herniation, trying to get rid of it with inflammation. It just can't get rid of it. It just turns a big lump of scar tissue / disc herniation / calcium. And it just sits back there. So this whole notion that your body can absorb these herniations is complete nonsense. And it's so out there on the internet. I hear people talking about it all the time. Oh, just give your body some time to absorb it. It's usually chiropractors and physical therapists that are telling patients that. And the reason they do that is they want your business. They want you to sign up for 6 weeks or 3 months of treatment. And they're going to say, well, during the treatment, your herniation will go away. And then they end up getting an MRI and they show the herniation, and then they show a different location later, like off to the left, and they say, look, it's gone. There it is, we got it. But it's not gone. They're just showing you a different profile picture, a different view. And the thing about MRIs is they're not real pictures. They're actually averages of structure. Okay? An MRI is not a real picture. It's not true image. All right, just about done. Let's just see if I'm missing anything else. There's a bone spur right there. That's the foramen I was working on earlier on the left. I don't really see much else, but I'm going to take one more look at it because that's the side that was bothering her the most. That's the annular tear, by the way. Some pieces of disc material floating up. Any other questions?
Yes, we have a question coming from Lanu, once more on YouTube.
Yes, Lanu.
Asking,
2 minutes.
people who have herniated discs but with no symptoms, do you have any advice for them?
Yeah, great question. People with herniated discs, 0 symptoms. I do not recommend surgery at this time. That may change in the future, but leave it alone. Now, it's important, Lanu, to understand you may not have symptoms because you're not doing any activities, right? A lot of people with herniated disc and pain, they end up like restricting their activities. So they don't live life. They stop enjoying things they enjoyed before. I recommend you stay active. That's a big piece right there. Come on. Oh, where'd you go? You can run, but you cannot hide. I have an endoscope. I can see all. I think that's it. So what I would say is, if you have no symptoms, be active. Do all the things you like. And then see if your symptoms come back. If they do, and you've learned to eliminate activities of your life that you enjoy in order to avoid symptoms. There's a name for that. It's called fear avoidance behavior. Fear avoidance behavior. It's a psychological term. It's real. I didn't make this stuff up. I would strongly recommend that you get back to doing things you love. And stop your fear avoidance behavior. Folks, we lost like 2 drops of blood. This is pretty much bloodless surgery. No metal, no artificial disc, no metal plate. We fixed 2 herniated, degenerated discs in her neck. Her neck will never look normal on the MRI. We don't get MRIs afterwards to look. What I do is I ask my patients, how are you doing? And the answer is always the same. I feel great. That pain is gone. The arm symptoms are getting better or gone. It's always the same. So this surgery works. We've done 1,000 of the cervical on the neck, Deuk laser disc repair. I've been doing this surgery 18 years, 18. We've never had a complication on the neck side. So safe. Show me any other surgery in the world that has 0 complications. ACDF, 50% complication rate, 50%. That means if you're going for an ACDF, there's a 50% chance you're going to have a complication. You go for artificial disc, 25% chance of complication. At least that's the published numbers, okay? Deuk laser disc repair, we've had 0. So that's less than 1 in 1,000. Any other questions?
No current questions.
Wonderful. All right, well, let's go ahead and run a testimonial and we'll end the stream.
Copy that.
4mm incision. Show that, Henry.
Yes, sir.
The whole surgery was done through that 4mm incision. No metal. Have a wonderful day. Put a little pressure, keep it there for a minute, just in case, and we're done. We'll get on with the next surgery. A 3-level DLDR, cervical next, and then we have a lumbar afterwards. Scope use is a 9. Good morning, I'm Dr. Deuk Majan. I'm here with one of my patients from Canada who traveled actually from Toronto to Florida to have Deuk laser disc repair to fix 2 herniated discs, one in his neck, one in his lower back. And you had your lower back done last week, and we were actually supposed to do your cervical last week, and we had our air conditioning break, and we got it fixed over the weekend, and you had your neck done yesterday. Yes, so you've actually had the Deuk laser disc repair done on your neck and your lower back. How's your lower back feeling?
Brand new.
Amazing,
As if it was never injured. I still am in shock. I can't believe that you were able to achieve this result after I've been suffering with this problem for just over 5 years now.
Yeah, since your accident.
Yeah.
Trauma is the cause of herniated discs. You had pain for 5 years. In Canada, what did they do to treat your pain in your back and your neck?
I started with medications, nerve meds, narcotic painkillers. I was instructed and told to have nerve block injections to help with pain management. I did physio, I did chiro. Finally, I got to a point where I started to do the nerve ablation therapy, and I did 2 rounds of that.
But the pain came back.
and the pain always came back, and I was looking for a repair, a permanent solution, so I can get back to, you know, having some normality of my life. And I found the Deuk Spine Institute, sent my MRI over right away. I had my consultation within not even 10 days with Dr. Deuk in person, like in Zoom. 3 weeks later, I flew out here and I feel like brand new.
It's amazing,
so thank
isn't it?
you. Yeah,
You're welcome. You're welcome.
This was life-saving for me because I didn't really have a great life before this experience.
And you can tell the pain is gone now.
Yeah, I was having numbing in my legs. There was days where I couldn't even walk. I was completely debilitated, stuck in the house, pain, numb. I thought I was going to be like paralyzed at one point. That's how bad it was.
And how are those symptoms now that you had the procedure?
Gone. I have full feeling back everywhere. Like, it's unbelievable. I can't believe it.
All with the Deuk laser disc repair. You could see we went in and we found the actual tear where the herniation came out in the back of the disc, and we used the laser to clean it out, debride it. Now here you are doing fantastic.
Yeah, thank you.
You're welcome.
So much.
Is there anything else you want to tell your fans out there?
I did my neck. I did my lower back. I had the worst symptoms. I came here, an hour each procedure. This is the day after. I had my procedure yesterday at, what time did you take me in? Like after 9 maybe?
Yeah, around 24 hours ago.
And I haven't taken any medication since I was discharged and gone back to the hotel. Not even Tylenol. Like, I feel great. It's unbelievable. I highly recommend anyone that's suffering like this to just come out and get fixed, because you will definitely have a way better quality of life. Don't suffer.
Yeah, don't suffer.
Don't suffer.
We can fix the back and neck.
There's
pain
a
here.
solution. He's the solution.
Thank you.
This is real. Everything you see on the internet about Dr. Deuk is real. Any negative reviews you read about Dr. Deuk are none. They're not real. They're just people that are just not happy with themselves, because I read them all on Google and I had to make this decision, and I'm very glad I did, because I believed everyone that was talking about their results, and here I am. So thank you.
Congratulations, my friend.
Thank you.
Enjoy the rest of your life.
Thank you.
Yeah, you're welcome. All right, let's get you out of here.